All right, so let's move on and go to zone 6, which is the dorsum of the hand. And here you get injuries from penetrating trauma. And again, MR is helpful at localizing the injuries and determining the extent and what anatomy is damaged. I was referring a little bit last time about the fact that the dorsal tendons have these slips, that fibrous tissue that go between them, which is why it's very hard to extend the fingers individually, whereas it's very easy to flex the fingers individually. It's because you have these cross-linking, but it also means that if you have an injury or a tear of a extensor tendon, then you still have some functionality in that finger where the tendon's torn, if the injury is proximal to where you have these transverse bands. Okay, Elior, what do you think of this case?
Right, so here,
This was
deep to the...
trauma.
Okay. Yeah, I see increased signal deep to the flexor tendons.
Wait, the extensor tendon here, right?
Yes, I'm sorry, extensor.
Okay, so you're talking about this area right in here.
Yes.
Okay. Yeah, and this turned out to be a tear of one of the muscles.
Okay.
Yeah, big surprise. Okay, Tayson.
All right. So I do see this, what I think is maybe a lax tendon.
Are you talking about this thing?
Yeah.
Okay. Yeah, this is a vessel.
Tendon.
Yeah. This is a vessel, so you have to. The veins often can be very serpiginous if you catch them this right. This is another trauma case, and it's a little hard to see with these images, and I don't expect you to pick this up, but we can see that there are actual edema if you compare these muscles between the fourth and fifth, and adjacent to the fifth, with the other muscles. And this is again, these are muscle tears of the interosseous muscles, dorsal interosseous muscles. Robert.
All right, so you're looking at the extensor tendon. It looks like there's a frank tear kind of at the metacarpal head, yeah.
Yeah, right. And this is a common type injury to see. There you see it, there you don't, and there you see it again. And these are usually from penetrating injuries where you get laceration of the extensor tendon.
That particular one that can be from hitting somebody. To be frank about it, I used to box a little bit, but in various situations. But one thing you don't want to do is hit somebody in the mouth with your knuckles, because you're going to wind up in worse shape than the person you hit. You'll get an infection very easily from hitting the teeth with your knuckles. That's a laceration you don't want to get. You better go to the emergency room immediately afterwards.
I'll remember that the next time I suck somebody in the mouth. Thanks, John. Elior.
Right. 80-year-old female, long-standing rheumatoid arthritis, inability to extend the fourth digit.
Unfortunately, Philip put arrows on these that I couldn't take off.
Yeah, he's pointing to an extensor tendon that looks lax there.
Yeah.
I think it's torn.
Just like you saw in that previous case of Tayson's, you always just have to check a little bit to make sure it's not a vessel, which is pretty easy to do. If you follow distally and proximally, you can easily differentiate and also look for flow characteristics between tendons and the vessels. And then here you can see that it's retracted and coiled up, which is typical of a completely torn tendon. And then if you look down here for the proximal retracted tendon, in this case, we could find it proximally here. So it's very characteristic of an acute extensor tendon tear. There we can see in the axial image, we can see a very abnormal fourth tendon there. Okay, let's move on now to the fifth, which is the area of the knuckles. The MCP joints, this is where you have the sagittal band and the extensor hood tears. And again, MR is helpful at characterizing the location of the tears. Now, when we get in toward the digits, the anatomy of the tendons becomes much more complicated. Here you can see the interosseous muscles over here and the tendons extending distally from them. We can see the extensor tendon, which comes over the top of the distal metacarpal head at the metacarpophalangeal joint, where it's held in place by the sagittal band that we're going to talk about. But then more distally, you can see that it breaks up into three components. One goes straight and attaches at the base of the middle phalanx, and then the others extend laterally here, come around the proximal interphalangeal joint, refuse up here distally, and then insert as the terminal tendon on the dorsal aspect of the distal phalanx. And then here we can see a dissection of the different anatomy. Here we can see the different slips of the extensor tendon. Here are the tendons coming in from the interosseous muscles. There we can see the distal tendons coming around and inserting distally here. This is a sagittal image showing a dissection where this is the extensor tendon here, and here's the sagittal band which goes over and holds the extensor tendon. And you could see if you actually make a fist with your hand, if you didn't have something holding that extensor tendon right over the distal metacarpal head, then that tendon would be pulled downward and would probably flop over to one side or the other. So what keeps it stable and in the midline is the sagittal band. So we'll talk about tears of the sagittal bands here, and then here we can see those other tendons and the interosseous muscles on the side of the joint. This is just a diagram showing the cross-sectional anatomy here. Here we can see the extensor tendon. Here's the sagittal band. We can see the fibrous sheets encircling the extensor tendon, holding it in place in the midline of the metacarpal head. And then we can see the collateral ligaments on either side here. And then we'll talk about the flexor tendon anatomy later. There are actually two of them. And then we can see the deep transverse metacarpal fascia here and the lumbrical muscles, which are on the palmar side, and there's the interosseous tendons on each side and the palmar plate. Okay, so the other thing that you notice, if you try to hyperextend the fingers, you kind of stop just kind of a little bit beyond being straight, and that's due to the sagittal band. The sagittal band attaches to the extensor tendon and does not allow much proximal displacement, so you tend not to be able to hyperextend the hand unless you're double jointed. But most people have this restriction by the sagittal band and keeping it from being able to hyperextend. Then if we look at the MR, cross-sectional anatomy with a cross-section and a cadaver, again, we can see the flexor tendons here on the palmar side. We can see the palmar plate, and then we can see the collateral ligaments, the extensor tendon, and here's the sagittal band coming across, holding the extensor tendon in place. Okay, I don't remember actually who's next. Tayson, why don't you take this one?
All right. So looking at the index finger, it looks like we have a defect of a sagittal band on the radial side.
Okay, see it intact on the ulnar side, on the radial side. It looks like there's a defect there. And this is the PD fat sat axial images, also showing that defect. This turned out to be a partial tear of the sagittal band. In this particular case, you can still see that the extensor tendon is in the midline. If it's a complete tear, very often when we do imaging, the way we position the hand, the extensor tendon will extend away from the side of the tear, where it's pulled over by the sagittal band from the other side. Now, there are, like everything else that we've seen, there are different criteria for determining the extent of the injuries here. Generally, with MR, we either say that it's either torn or partially torn. If there's displacement of the extensor tendon, then there's usually a complete tear on the side away from the displacement. If we have abnormal signal intensity, but the the extensor tendon is in the midline, usually that means that there's a partial tear. From a surgical standpoint, there's more subtle anatomy involved in these partial tears, but I don't think we can reliably visualize the different layers on an MR examination. Okay, Robert.
All right, so we have an NHL player rule out fracture, and looking at the dorsal aspect of the metacarpal there, the soft tissue, there's a lot of edema and maybe a tear of that extensor tendon, but
Okay. And then here are the axial images. You can see the non-symptomatic digits over here and compare them to the symptomatic digit. What do you think?
so the extensor tendon I think is intact, but there's a lot of soft tissue edema along that. Yeah, I guess it's the ulnar aspect of so the ulnar sagittal band. Looks like it's injured.
Over here. And then we can actually see that maybe this plus that is equal to the cross-sectional area of this.
Sure.
So it almost looks like there could be a longitudinal split tear here.
Mm-hmm.
If we go back here, we can see a lot of inhomogeneity here, but definitely there's an injury to this extensor tendon. And if we go to the PD FATSAT images, here you can see that there's actually probably a longitudinal split in that extensor tendon with a lot of edema and fluid surrounding that. And this was a tear of the sagittal band and a longitudinal tear within the extensor tendon here.
I think a few sutures would be intact. Necessary for this one.
Okay.
Because you're going to have to probably suture the skin anyway.
Okay. Okay, and this is just a sagittal band tear from a radiographic article from Clavero back in 2003, showing radial side displacement of the third extensor tendon due to an ulnar-sided sagittal band tear. Okay, see, Elior, what do you think of this former boxing champion?
Mm-hmm. Yeah, looking at that third ulnar-sided sagittal band, looks like a partial tear. There's no deviation of that extensor tendon.
Okay. And here we can see a lot of the edema surrounding the extensor tendon there. And I don't remember whether this was complete or not, but I would agree with you. There's no displacement. So I would call this most likely a high-grade partial tear. And you can see a marked thickening of that ulnar-sided sagittal band. This is high enough where I believe this patient underwent surgery. John, what do you think?
Well, being a boxer, probably would want surgery, but it all depends on the individual. I know one thing: if he's a professional, I wouldn't argue with him too much.
Yeah, right. Okay, Tayson.
All right. So I don't see the Radial side of the extensor, the sagittal band as well.
Yeah, so obviously the marker is where the pain is. So it's over the fourth metacarpophalangeal joint. Obviously, there's a lot of thickening and abnormal soft tissue here, but the extensor tendon looks like it's pretty close to the midline here, but then it's kind of a very diffuse abnormality. There, if we go to the sagittal images, does that help at all?
So a lot of edema.
Yeah, a lot of edema, soft tissue thickening. Here, if we go a little bit more distal, we can see a kind of an interruption there. And this again was a sagittal band tear without a lot of displacement.
Okay.
Okay, Robert?
All right, so here looking at, I think is the second metacarpal. Looks like the extensor tendon is dislocated. Yeah, right there.
So here's not the greatest images in the world, but we can see here's the second, the fourth, and the fifth. They're all dorsal to the metacarpal head, and here on the third, it's displaced on the ulnar side here. And then on the coronal,
definitely needs surgery.
yeah. So on the coronal images can be very helpful, showing the continuity of the tendon and displaced over here on the other side, on the ulnar side. Good. Elior.
Right, so looking in the region of the sagittal band and extensor tendon, looks like there's a defect in that extensor tendon. Be concerned about a tear.
Right. There you see it, there you don't, and there you're starting to see it again. Yeah, so that was a tear of the extensor indice, the second. Okay. Okay, Tayson, unable to extend fingers after trauma.
Okay, so I don't see an extensor tendon on the second digit there, and definitely the sagittal band looks deficient too.
Okay. Okay, you're on the sagittal images.
Yeah, we have looks like a full thickness tear
Okay.
proximal to the MCP joint.
Yeah, good. Not a lot of retraction. Okay, Robert.
All right, so here looks like there's a marker over the dorsal aspect of the second, or the what is it, the MCP. And looking at the MCP head, it looks like there's maybe an impaction injury dorsally. Yeah.
And then if you notice, the joint is not congruous.
Mhm.
The articulating surface of the metacarpal head is not centered on the articular surface of the proximal phalanx. And there may be a little bit of a bony impaction injury here, the dorsal aspect. And in this case, there's also a tear of the volar plate with
Subluxed.
yeah. So this was dislocated at one point, and this was an injury from hyperextension, and this impaction was from this part of the proximal aspect of the proximal phalanx, and with hyperextension, you got a traction tear of the volar plate. Okay, let's move on to the fourth and the third areas, which are really the proximal phalanx and proximal interphalangeal joints. You tend to get primarily extensor tendon tears here because that's the area that's usually involved with trauma as the dorsal aspect of the proximal phalanges. And again, MR is helpful at localizing injuries. Again, to remind us of the complexity of the anatomy here, here's that extensor tendon that comes down. It trifurcates. The central component slip inserts on the base of the middle phalanx, and then the lateral processes go around the central slip insertion to combine again distally here. Now, one thing to remember a little bit is the anatomy of these tendons where they attach near to the bones over joints. It's called the synovial enthesial complex. And at the extensor tendon insertion, what happens is at the insertion, you have a little cartilage. Looking under the microscope, the cells within the collagen fibers of the distal insertion has more of a cartilaginous appearance. Also here where you have a constant rubbing of the tendon against the metacarpal head, you get something that looks a little bit more like articular cartilage. And then we have the synovial sheath, synovial membrane, and the extensor tendon, and then obviously the articular surfaces of the joint itself. That can mean that you can have some inhomogeneous signal intensity in these locations. But here's that central slip. That's its insertion on the dorsal proximal aspect of the middle phalanx, nice and normal. Here it is on MR. Here we can see the cadaver section of that insertion. And on the axial MR images, we can see that central slip at its attachment to the dorsal aspect of the proximal middle phalanx. I don't remember who's next. Ilior, what do you think of this case?
Right on that sagittal view where that black arrow is pointing, looks like a tear of that central slip attachment to that middle phalanx.
So it's kind of thickened here, which in large part is due to that collagen, not the cartilage type, fibrocartilage, which is normal anatomy that we were just talking about, where it articulates with the distal aspect of the proximal phalanx. But here we can see there's a tear of that central slip. Now with that, you no longer have proper traction of the dorsal aspect of the middle phalanx, so you tend to get flexion of the proximal interphalangeal joint with that, because the lateral slips that we'll talk about in a minute come around on either side, come back together here to form this tendon that we're going to talk about in just a minute. They tend to produce also flexion of that middle phalanx, but also then extension of the distal phalanx. Therefore, you can get a fixed deformity, a relatively fixed deformity, a flexion of the proximal interphalangeal joint and extension of the distal interphalangeal joint. And what's that called?
This boutonniere deformity?
That's the boutonniere deformity. So you can see the physical reasons why you get the boutonniere deformity. This is classic if you have injury to this due to rheumatoid arthritis, but you can also get this same deformity when you get a central slip tear, which can be due typically to penetrating trauma. Okay, let's see. Taysen, this is a football injury.
All right. Looks like probably a centimeter or so proximal to the insertion of the central slip. We have a defect in the extensor tendon.
Yeah. So again, this is running through here. There's the normal on either side, so we can see the clear tear of the central slip here. This patient, and that was due to a laceration. Okay, so this dorsal anatomy here is often put together called the extensor hood, and that would be the central slip coming down and attaching to the base of the proximal phalanx, and then those medial and lateral fibers coming around to reform and attaching here distal. Oops, I'm sorry, this is metacarpal phalangeal joint. Here would be that central slip, and then there are the lateral that we're going to see in a minute, come around and attach here and attach distally. And of course, this is the area of the sagittal band in here. So that whole area is often called the extensor hood.
If you watch gorillas or monkeys walk, they usually walk with their paws flexed and their knuckles on the ground.
Okay.
That may be where all this comes from.
Okay. And here's the area of the proximal interphalangeal joints, right in through there. And here that's going to be the central slip there, and those lateral portions coming, medial and lateral portions coming around. And here is, we can see another tear of that central slip. And we'll talk about the flexor tendons in a little bit. Okay. Robert.
All right, so here looking at the proximal interphalangeal joint dorsally, there's a lot of soft tissue thickening and edema there. I don't see the tendon very well.
Right. And then here we can see that there's another, I don't know that we need all this many, but again, a rupture of the central slip with the lateral slips still intact. And this just shows the lateral slips, medial and lateral slips going on either side with that ruptured central slip. Okay, Elior. Well, that's all right. Yeah. Here's a marker again, ruptured, torn central slip. We've seen enough of these. So let me go on. Okay. And this was due to a dislocation. Okay, and then we go on to the zones 1 and 2, which is the middle phalanx and the DIP joints. And here we tend to have extensor tendon tears again. And again, MR is very helpful. And again, here we're going to see these lateral slips coming around, fusing to form the distal tendon, the terminal tendon, which attaches to the dorsal aspect of the distal phalanx. And so here's the gross specimen of that terminal tendon coming around and attaching to the dorsal base of the distal phalanx, and there's the MR showing that anatomy.
Now in Campbell's there, that's number 19. So since this has been written in 2003, a later edition of Campbell's has 19 of these. You can imagine you can go nuts trying to figure out what all these, what you really want to do with all those numbers, but you usually don't get to suture individual little tiny slips. You just take the whole bundle and suture it.
Okay. Elior, what do you think of this case?
Right, so here looking at the terminal band attachment.
Yeah.
Looks like it's torn.
Right. And here we can see the central slip, nice and normal here in this case, flexor tendons, and we can see an abnormal terminal tendon attaching to the distal phalanx dorsally there. Okay.
These are treated non-surgically with a splint. It's, for 6 weeks.
Yeah, I once knew a professional violinist who got this particular injury, and just like John said, there was no surgery. He was treated conservatively, and 6 weeks later, he was playing the violin without a problem. So it's interesting. Tayson, what do you think of this case?
Well, to stop for a second, I have had patients where they took the splint off because they were tired of wearing it and just kept their fingers extended with their other hand.
Yeah.
And they healed, and there was no problem.
Wow.
So it's a fairly easy to heal, but you got to behave yourself.
Okay.
All right, so 62-year-old male with swelling for 3 weeks. Looks like the terminal tendon is torn and proximally displaced. Central slip looks like it's intact.
Yeah, and here we can see that ruptured terminal tendon, right at its attachment to the bone. Good. Okay, Robert.
All right. Here again, it looks like there's a tear of that distal terminal tendon and some subluxation of the distal phalanx relative to the middle phalanx.
Yeah, and I'd be concerned in this case. I'd like to get better images. In this day and age, we would. whether or not there could be a little avulsion fracture here of the bone
Right.
that need to be evaluated further. Notice that there is flexion of the distal phalanx right there. And this is called a mallet deformity or a mallet finger, where you end up not healing properly, often because there's a bone injury involved, not just a tendon injury, and you end up with flexion of that distal interphalangeal joint. John, do you want to comment on this?
Quite a few surgeons will use K-wires for this and a splint.
Okay. Okay, now let's go on to the flexor tendons, and we'll talk about the carpal tunnel, and we'll talk about tendon tears, MCP, and then go out into the fingers. Uh, this, we're going to talk about this later, right? Oh, well. Well, let me just talk about this, but I thought this was at a later time. There are these the same levels, or as John said, now there are many more levels with more refined information. There's an area here, zone 2, on the flexor side here, where we can see that basically between the distal palm of the hand and the middle part of the middle phalanx, this is zone 2. And this is an area which is kind of called no man's zone. This is an area where you have a lot of difficulty in repairing these and have them work. This just shows how surgical repair in this particular area. John, do you want to talk about this so-called no man's zones?
No man's land is an area where should be treated by a hand surgeon. The problem is it's very difficult to put the flexor tendon back together because it wants to flex, and so the flexor tendon goes proximally, and it's very difficult to pull the tendon distally to suture to the distal portion of the tendon. And so what happens is I have that experience with my ex chief back where I did my pediatric orthopedics. He had a kid that had one of these in his own, and he sutured it with a finger hyperflexed almost where it brought tears to the kid. The kid was about 18 years old. Anyway, I told my chief, I said, this isn't going to work out. This is no man's land. It's going to tear, and you're going to have to redo it, and big problems. So the next morning, we're making rounds, and it ruptured, and the kid was yelling at my chief, and the chief started calling him names and walked out. If you did that today here in California, there would have been a big litigation, and my chief would have been in big trouble. But back in Cincinnati, that he knew every judge there, so he probably could do those things, which he did on numerous occasions. Anyway, that's just a little background. Anyway, these are difficult to treat, and let the hand surgeon handle it. And it's a difficult problem.
Okay. Well, let's move on now to the carpal tunnel, and we'll start proximally, and then we'll go distally. Here, you tend to get traumatic injury. You can also have inflammatory disease, such as rheumatoid arthritis, which can cause tenosynovitis, flexion, and increased pressure within the carpal tunnel. You get instability, such as DC and VC instabilities, which can follow this. You have masses. We'll talk about a few of them. And then in pregnancy, you can often get tenosynovitis, which can lead to symptoms in the carpal tunnel. I don't remember where we were. Let's see, Robert, why don't you take this one?
Sure. Uh, so here, I guess, looking at the carpal tunnel, uh, hmm, the median nerve looks maybe a little bit thick and increased in signal, but not not too dramatic there. Yeah, looking at the flexor retinaculum, there may be a little bit of, I guess, discontinuity there.
Okay, so this looks post-operative, right?
Yeah.
And then here we can see interruption of that flexor retinaculum, but this was actually due to laceration by glass. Okay, so this is kind of what the flexor retinaculum looks like. It goes between the hook of the hamate and volarly across the wrist here with the flexor tendons deep to the retinaculum. It should be relatively flat, like we're seeing here. We should have little separation between the flexor tendons. When it becomes bowed like this, and some separation of the flexor tendons, and you've got to worry about some process which is increasing the pressure within the carpal tunnel. And that if you have increased pressure within the carpal tunnel, you can compress the median nerve, and you can also, if that increased pressure is due to increased synovium and tenosynovitis, you can have pain involving the flexor tendons, and that syndrome, a complex of symptoms, is called carpal tunnel syndrome. Here are just some other examples where we have bowing of the flexor retinaculum on these old scans, T2 weighted image with some edema within the median nerve and a little bit of increased synovial thickening here. Okay, let's see, Elior, what do you think of this one?
We've got a 28-year-old male, pain wrist in both 1 month ago. It looks, I see the median nerve, but I'm trying to figure out what that structure is to the right next to it.
Yeah, it kind of has the same signal on these fat suppressed images as maybe synovium over here, possibly fat. Here we go, another fat suppressed images in a little different location as we go more distally. Maybe a little bit of thickening here. Sagittal image. Coronal images here.
Is this an accessory muscle?
Through here.
Looks like muscle.
Yep, this was an anomalous flexor digitorum superficialis muscle going to the index finger, which increased the pressure because it took up a lot of space in the flexor retinaculum between the hook of the hamate here and the triquetrum. And this was carpal tunnel syndrome due to an accessory muscle. Good. Yeah, just another example of an accessory muscle. Okay, Tayson.
All right. Definitely looks like we have bowing of the flexor retinaculum and some flattening of the median nerve.
A little bit of increased synovial thickening here around the tendons. This is a very old study, and this just shows bowing of the flexor retinaculum. And this is a patient who also had symptoms of carpal tunnel disease. Now, this just shows that the median nerve can look different depending upon where you image it. This is proximal, and here's in the flexor retinaculum in this location, and we can see that approximately the nerve is larger than it is in the flexor retinaculum. In cases of carpal tunnel syndrome, if you have increased pressure, you can get a decrease in the cross-sectional area of the median nerve in the carpal tunnel, and widening of the median nerve, both proximally and distal. That's called an hourglass appearance to the median nerve, as you would see it if you decompress this area surgically. And when you get that with carpal tunnel disease, often you'll get an increased fluid within the proximal and distal nerves. And that this is a little bit more reliable sign of carpal tunnel syndrome, though there's still a lot of controversy between symptoms of carpal tunnel syndrome and MR findings. This is one that in some studies is more reliable than just looking at the bowing of the flexor retinaculum. This used to be an issue a decade ago. Carpal tunnel releases was a very common surgery, probably the most common surgery in the hand. And then it found out that a lot of patients did not do well in long-term follow-up from that particular surgery, so insurance companies stopped paying for it, and the amount of carpal tunnel surgery we see now is markedly decreased compared to what it was a decade or two ago. But we'll talk more about that in a minute. And then here we can see proximal large nerve, which looks edematous, and the flexor retinaculum is more normal size and not so edematous. And this is, again, edema within the nerve. Okay, let me see. Robert, what do you think of this case?
Let's see. So proximal to the flexor retinaculum. Not entirely sure. There's some fluid, I guess, surrounding the flexor tendons there.
Good. Good. Okay, and then this is at the flexor retinaculum.
It looks like,
Yeah,
maybe a little bit of bone in that flexor retinaculum, but I don't see a whole lot.
a little bit right. So about what we basically see is fluid within the flexor tendon sheath proximal to the tendon, and this is actually the median nerve, which is also much larger proximal than we see it inside the flexor retinaculum. So this was another patient who actually had symptoms of carpal tunnel syndrome with tenosynovitis and some swelling of that nerve. So this was a study where they looked at MR criteria for looking for carpal tunnel syndrome. And one of the things they looked at was the cross-sectional area of the median nerve. They measured it proximally at the inlet and at the tunnel outlet and distal to the tunnel itself. They also looked at retinacular bowing and a flattening ratio, which is the ratio between the cross-section of the median nerve at the inlet and outlet, and then the ratio of the cross-sectional area at the inlet and outlet. And then they looked at relative signal intensity, and all of these actually correlated with symptoms except for the flattening ratio, how much flatter it is, AP diameter versus lateral. What they recommended is looking at the cross-sectional area. If it's greater than 15 millimeters square at the inlet, right proximal to the carpal tunnel or outlet, they said that this was a 98% indicative of correlate with symptoms of carpal tunnel syndrome. If it's greater than 19 millimeters in cross-sectional area, then there's a very high correlation with severe carpal tunnel syndrome. So they recommend looking at the ratio of the cross-sectional area of the inlet, right proximal to the carpal tunnel versus the actual cross-sectional area inside the carpal tunnel. John?
A real diagnosis clinically can be made, and it's pretty accurate. Hyperflexion, which is called a Phelan test, after 30 seconds, it becomes numb and painful. Squeezing the wrist is another test, which is supposedly, by some surgeons, more accurate. It develops severe pain. And of course, swelling and Tenel sign by palpating the wrist, the volar aspect produces tingling and pain. And if it's real, the patient will want to punch you. But one of the biggest problems with with carpal tunnel is workman's comp. It's very commonly claimed to be injured at work, and a lot of these people are phonies. And you have to have good examinations to clear the deck.
Okay, thank you. So this was an article in the American Academy of Orthopedic Surgery journal, and they said diagnostic algorithms look at history, physical examination, like John was just talking about, and then electrodiagnostics can be helpful if it's not definitive. They do not recommend imaging routinely in making this diagnosis. It was very common to image these patients with workman's comp patients because it was basically covered in the and a lot of them went to court, and it was what was thought by many people to be more of an objective way to evaluate whether the disease existed or not. But
And
from a medical standpoint, imaging is not routinely indicated.
I think imaging is very helpful. I don't think electrodiagnostic is very helpful.
Okay.
In my experience, and I've done quite a few of these, surgically and non-surgically. I had a patient that tried to commit suicide about 20 years before I saw her, and she finally got tired of having numbness in the median nerve distribution, but she did have some function, and there was some atrophy, but not much. I had electrodiagnostic studies done by a local individual. We only had one that really knew how to read these, and he wasn't available. He retired. So anyway, I operated on her, and she had one tiny nerve that was happened to be on the side where the muscular component was intact, and I had to reconnect the nerve. Fortunately, it turned out good, and I'm not a hand surgeon. So anyway, one tiny little fiber misdiagnosed the condition. Basically, the neurologist said that I shouldn't operate on this patient.
Okay. Uh,
One other little thing I may mention is people have connected the median nerve to the tendons when they had wrist lacerations. That's not terribly uncommon. Residents working at night and somebody comes in with a lacerated wrist, they screw up sometimes and suture the median nerve to one of the flexors.
okay. Wow. I forgot who's next. Anybody remember?
I think I am.
Okay.
Okay, 49-year-old woman, pain for 2 years with nocturnal pain.
Okay. Ultrasound. And here we can see flow in the vessels. So this is actually the flexor retinaculum area in through here. Here we can see that there are an artery and a vein going through the area of the flexor retinaculum. Here are the sagittal images showing the flow and the pulsatile nature of it. Here are the MR.
Mm-hmm. Yeah, next to that median nerve, do we see some vessels next to it?
Right. And then here just an angiogram through this particular area. And what you can see is that there's actually a lot of variation in the anatomy of the median nerve. You can have one, two, or three fascicles of the nerve. And when you have that, you can often have vein and artery going along with the median nerve into the flexor retinaculum. So there's a lot of variations here, but don't be too surprised if in looking here you can actually see vessels going along the median nerve. Sometimes it's bifid with vessels in between the two. So there's a lot of variations in the anatomy of the median nerve through the carpal tunnel. This just shows multiple variations of nerve, arteries, and veins that can occur as normal anatomy of the median
The
nerve.
flexor retinaculum is very tight and very thick. So, and you got to be very careful how you cut it. Some people use endoscope to do arthroscope to do the surgery, which works okay if you can see it well. The main thing is stay away from the medial side because that's where the nerve to your retainer muscles is. You don't want to ever cut that because you'll really have a problem. Anyway, there are reasons to do surgery, and some people don't need a surgery. I have seen emergencies of cases, especially one woman I had was pregnant, and both wrists she had carpal tunnel to such a degree she was screaming for morphine. And my partner and I operated on each wrist. One did one, the other one did the other, and that relieved the symptoms.
Right.
And then it didn't recur.
Good. Very good.
So, but sometimes these can be extremely painful, and especially in pregnant women out of nowhere, it just happens from swelling.
Right. Right. Why don't we stop here and we'll pick up at this point next week.
Have a good weekend, everybody.
Thank you. You too.
Thanks, John.
Thank you. You too.
Monday.
Thank you.